safe. Okay, I think it's time to start the last session of this meeting. It's been really great 2.5 days so far, and I really appreciate for all of you, particularly the moderator, the speakers, and all of you who are attending the meeting. So we have kept the best session of the meeting for last. We have a great, this title of this session is New Therapeutic Strategies in Treatment of Pancreatitis. We have really 3 big famous speakers for that. And without further ado, I know we are a little behind. I would have our co-moderator and Anna Gukowskia, who just got a Lifetime Achievement Award yesterday. So Anna, please start this session. Anna, you there? I see you there, Anna.
The first talk is by Marcus Lerch, who is a renowned pancreatologist. He is a professor of medicine and the chair department of medicine in Graceful, and you can read his biography more in details in the program. So his talk is Pancreatitis in patients with lipid disorders. Okay.
Hello, everyone. I'm very sorry to not meet you in person in Miami, but at the APA virtual meeting, but that's due to the pandemic, and I will talk about pancreatitis in patients with lipid disorders. I have no real disclosure other than I have been adjudicator of some of the studies I'm going to show you on behalf of Axea and Cova Pharmaceuticals. When we talk about lipid disorders in the context of pancreatitis, we still use the more than 60-year-old classification by Dr. Donald Fredrickson, who was director of the NIH and classified lipid disorders according to paper electrophoresis. And we have different types. You can see that they have grown over the year: type 1, 2A, 2B, 3, 4, and 5. And the important thing to remember is that pancreatitis, when it occurs in the context of lipid disorders, occurs in conjunction with type 1, type 4, and type 5. And what these have in common, at least the type 5 and type 1, that it's essentially chylomicrons that cause the disease, or in other words, that's the equivalent, high triglycerides. Pancreatitis is not a disorder of high cholesterol. That's where cardiologists are concerned about, but of triglycerides. Older guidelines say that the risk of pancreatitis increases when triglyceride levels are raised above 2,000 milligram per deciliter, and that's the risk. We know today that this is not really true. There's a very elegant study from Scandinavia. It's a population-based study, and they had access to all patients from more than almost 120,000 Danish patients. And what they found is that even mildly elevated triglycerides, here we're talking about twice the upper limits of normal, already doubles your risk of pancreatitis. And when your levels are raised about 443 milligram per deciliter, you already have a 9-fold increased risk of developing pancreatitis. So the old classification, over 1,000 or over 2,000, no longer holds, but your risk is already developed, increased at lower levels. This is a very elegant study from Hungary, from the Hungarian Pancreatitis Study Group, and they differentiated between different causes like biliary, alcohol and high-fat diet. What I want to point out is that in association with hyperlipidemia, that is hypertriglyceridemia, the risk is 6.1%, and even greater for males than for females. And what's even more concerning is that in the severe group of pancreatitis, they account for 19%. That means not only is hypertriglyceridemia a risk factor, but it's also a factor that may influence the severity of the disease. And that has been studied by different groups, and I will get to these later. What raises the levels of triglycerides? And before we come to genetic disorders, I want to point out that diabetes mellitus is one of the risk factors for hypertriglyceridemia, particularly the diabetic ketoacidosis, and alcohol is. By far the most patients I see in the emergency room have consumed large or moderate amounts of alcohol. They developed high triglycerides and they have pancreatitis. It's very debatable whether the alcohol or the triglycerides cause pancreatitis in this particular event. But keeping these patients in the hospital for 48 hours usually lowers the triglyceride levels already to normal. There's a number of other diseases. Pregnancy is one factor that can raise lipids, and there is a number of drugs that I don't want to get into much details about this. What are the genetic causes? This is a very elegant study from Canada. And what these authors have shown when they looked at an entire population is that if levels are above 2 millimolar, there are around 32 different SNPs in different genes that can be associated with high triglycerides. However, if they're above 10 millimolars, the number gets much, much smaller. And then we have often a monogenic disease, the most common being lipoprotein lipase mutations or ApoC2 mutations. Let's get back to the severity issue. You all know that pancreatitis comes in different flavors. That means very mild cases and very severe cases. And we have learned that having organ failure, that could be renal failure, cardiovascular failure, or pulmonary failure for longer than 48 hours is a very good indicator of more severe pancreatitis and of higher mortality. Dave Whitcomb and his group looked at the triglyceride levels of the patients in their cohort. And what they found is that the need for intensive care, the advent of pancreatic necrosis, or persistent organ failure were all greater when triglyceride levels were elevated in his patients. So we not only have a risk factor for onset of the disease, we also have a risk factor for having a more severe disease if your triglyceride levels are up. This is a single center study of more than 1,000 patients from China. And they confirmed that either mortality or organ failure or necrosis are greater when triglyceride levels are up. What I find most interesting about this study is with cholesterol, it's the opposite. So high cholesterol levels reduce your risk of necrosis, reduce your risk of persistent organ failure, and even reduce your mortality rate. So the perspective of a gastroenterologist, pancreatologist, and that of a cardiologist are entirely different. We look at triglyceride levels and what they do to the pancreas, and the cardiologist looks at cholesterol levels and what they do to the vasculature, and these are completely different perspectives. What do the triglycerides or the chylomicrons do on the cellular level? And I just want to highlight two studies. This paper here looked at an unsaturated fatty acid, palmitoleic acid, and a saturated one, palmitic acid. And the interesting thing is they looked at pancreatic SNI and calcium release, and what they found is that it's the unsaturated fatty acid that does the damage, but not the saturated fatty acid, the one that cardiologists are mostly concerned with. This is another study, and just one of the slides from the Vijay Singh's group, published in Science Translational Medicine. And I just want to highlight that again, it's the linoleic acid, the unsaturated acid, that induces inflammatory cytokine release from SNO cells, and not the palmitic acid, the saturated acid. That's why some authors, including Vijay Singh, have made the phrase popular that he likes butter. This is my first summary high triglycerides, which is the same as chylomicrons, increase the risk of pancreatitis even when plasma levels are only mildly elevated. High triglycerides and low cholesterol are associated with greater pancreatitis severity. Exogenous factors, but mostly genetic factors, are responsible for high triglycerides, some with defined genetic syndromes like FCS or lipoprotein lipase deficiency or ApoC2 deficiency, and unsaturated, not the saturated free fatty acid generated from triglycerides, induce SNR cell damage and drive inflammation. So what if you have such a patient and he comes into the emergency room? One thing, ask about alcohol, because that could be a driver of his hyperlipidemia and it rapidly goes away. The other thing is start with insulin. It drives up lipoprotein lipase activity and it lowers triglycerides. Some studies, particularly from China, have shown that adding heparin has an additional effect of getting them lower. And you should do that until the triglyceride levels are below 500. If the patient has hyperglycemia, insulin alone is fine. If the blood sugar levels go too low, just add glucose to it, and that will help more than 90% of your patients. If you cannot lower the levels because of some inherited disorders, within 36 or 48 hours, you may consider plasmapheresis or plasma exchange. And it has less complications if you don't use heparin, but citrate for the plasma exchange. Or whenever worrisome features develop, like hypocalcemia, lactic acidosis, progressive systemic inflammation, or organ failure. That's a point. There's very few randomized controlled trials for plasmapheresis and plasma exchange, and this is mostly based on the recommendations of Anders Gelrud and Dave Whitcomb on UpToDate. They haven't changed much, but we're working on a guideline right now. There is one option I want to introduce to, which is not an acute treatment, but a chronic treatment. There's a new group of drugs which are antisense oligonucleotides coming increasingly for a variety of metabolic disorders on the market. One is volanesorsen. It impairs the production of ApoC3. ApoC3 is a potent inhibitor of lipoprotein lipase, and therefore volanesorsen corrects the LPL deficiency in a similar way as insulin does, but it's much more effective. You can see this here, that these are the lipid lowering concentrations from two different studies, one with genetic FCS alone and one for mixed causes of severe long-term hyperlipidemia. And you see that it greatly reduces the triglyceride levels more than any other drug that is on the market. And it also reduces the number of episodes of pancreatitis. The final paper is being submitted and I think will come out very soon. I thank you all for your attention. I'm sorry that this is all virtual. These are all the people I have worked with over the years on the pancreatitis studies and cell biology. I thank you very much for your attention.
And unmute yourself, please.
Yeah, sorry. So thank you very much. Very interesting, informative, excellent talk. So I have one question. Marcus is on?
No, he should be here. Marcus?
Yeah.
I'm here. Can you hear me?
Oh, yes. Okay. So one.
You should be able to hear me.
Yes, we do. Okay.
Good.
So do you hear me?
Yes.
Great. So the question is a great talk, excellent talk. One question from basic science. Do you know how these triglycerides affect acinar cells lipid metabolism? Because like increase in LDL or chylomicrons should affect entrance of, for example, cholesterol in acinar cells. So is there anything known on this?
That's a very good question, and I thank you very much. I'm not a lipidologist. I look at lipid disorders only from a clinical perspective, but I've talked to lipidologists. The best studies out there right now are from Vijay Singh and others who are in the room. However, it is very hard to study chylomicrons effect on acinar cells, and the lipidologists I talk to say there are numerous problems by just going ahead and using triglyceride chylomicrons or VLDL particles on acinar cells and compare them. I think the best available evidence we have at the moment is the comparison of fatty acids directly, saturated versus unsaturated fatty acids. However, whether that translates into the real situation in humans is a little arguable.
Thank you. Are there more questions? I
think Vijay Singh is here online.
Yes.
Can you unmute yourself, and you have a question also, and you can answer the other one also. Vijay, are you there?
Yeah, yes, I'm there. Can you hear me?
Okay, great.
Yes, Marcus, great talk. I loved it. And I absolutely agree with the interesting relationship that you showed between HDL cholesterol and the inverse relationship with severity. Interestingly, if you look at HDL cholesterol, it's esterified, and the fatty acid chain that comes in HDL, which is high density protein, is interestingly a saturated fatty acid chain. HDL is mostly saturated cholesterol. It is not, unlike LDL, as you go into LDL and VLDL.
Vijay, I think you need to unmute yourself. Please unmute yourself.
Could part of my question come through? Did some of it come through?
Some of it.
Yes.
Last part.
Yeah. So my question is, since HDL is mostly saturated, LDL cholesterol is mostly unsaturated, and VLDL is even more unsaturated. Well, do you think there is a relationship of that to the severity of pancreatitis apart from the triglycerides?
And
yeah,
thank you.
That's a very good comment, Vijay. What we have some evidence that what the cholesterol does directly is stabilize cellular membranes. I think this is most of the effect we see. Cholesterol as being protective. I think cellular membranes of acinar cells and probably also immune cells are more resistant when they have enough cholesterol as opposed to triglycerides. Are there more questions, Anna?
Yes, and regarding cholesterol, there is a question from Aurelia Lugier. Can you comment on the use of statins, cholesterol levels, and risk of pancreatitis?
That is a very good question, and in my mind, when I looked at the literature, it's very conflicting. There are studies that say that statins have a protective effect for pancreatitis, and there are others that say they make pancreatitis worse. So, in my view, the jury is still out on the statins. Statins have some off-target effects on triglycerides also, although it's really minor compared to the effect on cholesterol. I would conclude that the role of statins in pancreatitis as being preventive or not is still controversial.
Thank you. There's also a comment from Shmuel Mualem, and it says, congratulations for illuminating talk. Low levels of triglyceride are very toxic to islets. Any contribution to induction of pancreatic damage at the low triglyceride level?
Hi, Shmuel. I'm sorry I can't see you on camera. I would love to. Well, the direct effects from Vijay's study and from the Chinese study are very clear that they induce pathologic calcium signals and they induce cytokine release from acinar cells. So they are considered damaging on acinar
Another
cells.
question. Yes, one more question from John George. Great presentation, Dr. Lerch. Can you comment on use of heparin in hypertriglyceridemia, pancreatitis, mechanism of action? We have been using more insulin, but not heparin in clinical practice.
That is true. The current recommendations do not include heparin. However, apparently in China, hyperlipidemia-induced pancreatitis is so much more common than in Western countries lately, and the evidence that that heparin has an additional beneficial effect on LPL activity and on the outcome of pancreatitis comes from 2 studies from China. So while there's no conclusive evidence, I must say there are very, very, very few randomized controlled trials on how to treat hyperlipidemia in patients with acute pancreatitis. There is some evidence that it has an additional helpful effect to insulin, which raises LPL activity, glucose, and also heparin to some degree.
Thank you very much. I think there are several more questions which we may look at the chart record and answer, because we need to move to the next talk. Thank you.
Thank you.
Thank you.
And thank you, Marcus.
Thank you very much.
Very nice talk. And it was good to see you, Shmuel, though briefly. Let's move to the next talk. Next talk is on exocrine pancreatic insufficiency and role of PERTs in that. Our next speaker is Dr. Chris Forsmark. Doesn't need much introduction at all. Chris is a professor of medicine and chief of GI and hepatology and nutrition in University of Florida. He got his degrees from Hopkins and did all his training from UCSF, really blue-blooded. And he's, I think, clinical and research expert on chronic pancreatitis, every aspect of that, and his diagnosis, epidemiology, and all of that. He, of course, has been a past president of American Pancreatic Association, and also got our Lifetime Achievement Award a few years back. Chris, please take it away.
Well, hello, everyone. Welcome to the first and hopefully last virtual meeting of the American Pancreatic Association. As part of this session on new therapeutic strategies, I'm going to be talking about pancreatic enzyme replacement therapy, which is not strictly speaking a new therapy, but is something that is used inconsistently, certainly in the US. When we think about the development of exocrine pancreatic insufficiency and pancreatitis, obviously the first condition which springs to mind is chronic pancreatitis, a relatively uncommon problem, but with a significant proportion of patients that develop exocrine insufficiency in the neighborhood of 30 to 50%. And there are risk factors for the development of exocrine insufficiency. Certainly duration is one, but also etiology. On the upper right is a little chart demonstrating the median time to development of exocrine insufficiency in alcoholic versus idiopathic chronic pancreatitis. And you can see that alcohol-induced disease develops exocrine insufficiency sooner. And there are some other etiologic risk factors that seem to impart a higher risk of exocrine insufficiency, like smoking or genetics. Cystic fibrosis is a common cause of exocrine insufficiency, as is pancreatic surgery and pancreatic cancer, and a variety of others, including severe acute pancreatitis. Now, in addition to these patients, there's a variety of others where we might encounter exocrine insufficiency. One of the more interesting ones are patients that have acute pancreatitis or relapsing pancreatitis, and it's not severe enough to cause necrosis, but who nonetheless develop exocrine insufficiency. In that chart on the upper right looks at the pooled prevalence of exocrine insufficiency in patients with either severe in the red or mild in the blue acute pancreatitis, and the x-axis is time since admission for acute pancreatitis. And you can see that even in patients with mild pancreatitis, there is a significant long-term risk of exocrine insufficiency. And there are others that are listed on the slide. Diabetics are certainly an area of interest, as is the folks at the extremes of age who may develop features of exocrine insufficiency. And one of the challenges in knowing who does and who does not have exocrine insufficiency is we don't have very good diagnostic testing. We rely a lot on fecal elastase, which is actually not fecal elastase, it's a different protein. And we use various cutoffs, less than 200 micrograms per gram of stool, or less than 100. The lower the cutoff, the more specific is the test. And there have been a number of studies on this, on fecal elastase, and one systematic review and meta-analysis done relatively recently noted a fairly good sensitivity and specificity of the test, but the problem is in a low prevalence population like we're dealing with, it still translates into a significant false positive rate. That is, lots of patients have low fecal elastase who do not have true exocrine pancreatic insufficiency. A few caveats: the stool sample needs to be solid or semi-solid because watery stool dilutes it. It doesn't require the patient stop pancreatic enzyme therapy. It is variable, at least in my experience, so it's worth testing on more than one occasion. And finally, I never make a diagnosis of exocrine insufficiency based solely on a low fecal elastase. It has to be the right patient, the right clinical setting, and being aware of some of the other confounders that can affect fecal elastase levels. So let's turn now to exocrine insufficiency. Obviously, the reason we want to treat it is to prevent the various consequences. These patients commonly, obviously, have steatorrhea, but interestingly, they may not have diarrhea. Weight loss is relatively frequent, and they often have difficulty in managing concomitant diabetes if it's present, since it's less predictable nutrient absorption. And there's even some very interesting recent data that developing exocrine insufficiency increases the lifetime risk of getting diabetes. So there is an endocrine and exocrine interaction, which is significant. These patients obviously maldigest, and they can get a variety of consequences. Osteopenia and osteoporosis probably top of the list due to calcium and vitamin D deficiency, but they can develop deficiencies in other vitamins, particularly fat-soluble vitamins, as well as a variety of trace elements, and even B vitamins. The picture on the upper right is a patient of mine who allowed me to take his picture, who's developed pellagra in the setting of chronic pancreatitis. That's the discolored rash here. And there's good data that having exocrine insufficiency has negative adverse outcomes in terms of need for hospitalization, quality of life, and even some data of excess mortality. So if you've identified a patient with exocrine insufficiency as you're considering starting enzyme replacement therapy, what are some baseline studies you could consider? Well, certainly anthropometrics is a reasonable thing, at the minimum looking at BMI, trying to make some guesstimate of muscle mass or strength, either by just a visual estimate, or by measuring skeletal muscle mass on a CT scan, or by measuring hand grip strength with one of those dynamometers. There's some basic nutritional parameters that are reasonable, things like retinol binding protein in particular. You should get fat-soluble vitamin levels, as well as, at least on one occasion, when you're starting out, B vitamins, folate, and magnesium, because these can be deficient in these patients. And because of this endocrine and exocrine interaction, hemoglobin A1C. I think a DEXA scan is prudent because osteoporosis and osteopenia are very common. There is a recent study suggesting that the majority of patients with chronic pancreatitis never get a DEXA scan. You should refer them to your appropriate institutional resources for smoking and alcohol cessation, and I think counsel them on lifestyle parameters, and in particular keeping physically active to prevent osteoporosis. So those baseline evaluations are sort of my standard list that I would order. obviously you want to make sure you have the diagnosis accurately, and then you're going to start therapy. And the general rule of thumb is that it takes about 1/10 of the normal output of the of pancreatic lipase to sufficiently improve digestion and absorption. And that turns out to be about 90,000 USP units of lipase per meal, which is about 10% of normal. Many of these patients will have some residual enzyme secretion from their pancreas, and there is a gastric lipase which can compensate to some degree for the loss of pancreatic lipase. But despite that, still a minimum starting dosage is around 40 to 50,000 units of lipase with each meal, and half as much for snacks. You can weight-based dose it if patients are really small or pediatrics. These need to be taken during the meal, not before the meal, not after the meal, and patients are often confused about that. As I mentioned, you should do these baseline studies as well as you're initiating therapy if they've not yet been done. So these are the products that are at least currently available in the United States. They're all brand name products. They come in various sizes. The numbers there are the lipase content per capsule or pill. 4 of these products are enteric coated. That is, they release at a particular pH, generally in the upper small bowel. 1 is non-enteric coated, which releases sooner, but is susceptible to degradation by gastric acid. That's Viacase. So you usually need co-treatment with an acid-reducing agent if you're utilizing Viacase. It's, I think, important to remember that even when we have patients on a dosage that would seem to be at least 10% of the normal pancreas, we do not fully correct steatorrhea. And this is just from a meta-analysis. And if you look here on the upper chart, this is the coefficient of fat absorption, which is how much of the dietary fat's been absorbed, and normal is around 93%. And you can see in these variety of studies, on placebo, about 67% of fat is absorbed. It goes up to 83%, but not the 93% that's normal. And same if you look at sort of baseline versus on PERT for individual patients. So these enzyme replacements are not as effective as normal pancreatic secretions in normalizing fat absorption. And whether that's important or not, I think depends on the individual patient and their nutritional status. So we have a group we've talked about that are at high risk. Certainly chronic pancreatitis would be a big group, although we might consider others. And so another question really is not, are we aware that they are at risk of having exocrine insufficiency, but do they get prescribed replacement therapy at the right dose? Are they taking it? And if not, why not? And is it working? And finally, as a subset of is it working, are they being monitored, for some of the more serious complications like metabolic bone disease? So there are a number of studies which have looked at various populations to try to estimate how commonly patients with chronic pancreatitis are treated. This is an analysis that Diraj Yadav and I were part of, which looked in the US. There are other studies from Europe. And this was just looking at patients who were insured, so they had commercial insurance and had a diagnosis of chronic pancreatitis based on ICD-9 codes. And we looked over a significant period of time, and within this insurance database identified around 37,000 individuals with chronic pancreatitis. And then we were able to look at the various billing codes and prescriptions, and we found that only about 6.5% had at any time had a test to look for exocrine pancreatic insufficiency, like a fecal elastase or fecal fat. 30% had been actually received a prescription for enzyme replacement therapy, but of those, only about a third received what we thought would be a minimally appropriate dose, which is around 40,000 lipase units per meal. So this third of a third translates into around 10%. So about 6.5% get tested, and about 1 in 10 receives a minimally effective dose. And this data is mirrored by studies from Europe. So we kind of know what to do, but it often doesn't happen. The other question that patients often ask is what should they be doing dietary-wise? And there are numerous recommendations that are out there. Most of them are low fat or very low fat or no fat. Many of the recommendations also include multiple small meals rather than larger meals. There's really no science to support these recommendations, although I will put a call out for a cookbook here from the National Pancreas Foundation, which I'm part of. But I guess my suggestion would be to avoid the very, very low fat diets, because this just increases the risk of fat soluble vitamin deficiency. Textbooks often mention medium chain triglyceride oil. I've never used it in the last 40 years though. And I think everyone needs calcium and vitamin D. So you start treatment, you think you're on the right dose. Is it working? How do you tell if it's working? Well, there are some things that sort of I find useful. And certainly the clinical response is the most useful. Is the steatorrhea gone? Is their strength and energy improving? Is their anthropometrics or grip strength improving? Are their fat soluble vitamin levels normalized? Is their retinol binding protein normalized? What's generally not helpful are repeating fecal fat measurements. They're so inaccurate that doing them again and again usually not helpful. Fecal elastase, once I've made the decision I'm going to treat them, I don't really check that anymore. And the other thing that's not terribly helpful is whether they're sort of very non-specific. So if they have a little excess gas, a little excess bloating, but they're otherwise responding, I don't find that terribly helpful in helping me decide whether I need to increase the dose. But it would sort of depend on the patient and the severity of those symptoms. If they're not responding, why not? Why may that be? What might be the explanation? Probably the most common is an inadequate dosage. Either the prescription was not appropriate, it wasn't a high enough dose. At least in the US, around a third of prescriptions are never filled, and it seems that may be primarily due to the fact that these agents are quite expensive. If that's not the answer, if they actually have access to the drug and they're taking it in the right dose, the next question is, are they taking it at the right time? And the last is if they're on the non-enteric-coated preparation, are they avoiding acid inactivation by taking at the same time an acid-reducing medicine? And if none of those are the answer, then start thinking about an alternative diagnosis, and small intestinal bacterial overgrowth is the most common one. So just to summarize, exocrine pancreatic insufficiency is common in patients with chronic pancreatitis and these other diseases that I mentioned. We know that it's helpful to treat patients. We know how to treat patients. We know what the dosage is, but unfortunately, despite all that, few patients are tested and fewer receive PERT therapy, even in patients with chronic pancreatitis who we believe, based on the duration and etiology of disease, might be a particular risk for this. Remember that it's not just chronic pancreatitis. There are a variety of other conditions, and certainly previous acute pancreatitis is becoming more commonly identified as a contributor to exocrine pancreatic insufficiency. We suffer from the lack of a widely available and accurate diagnostic test. So we have clinical suspicion and fecal elastase, but they're both sort of quite inaccurate, unfortunately. Once you make a diagnosis, or once you believe you have an accurate diagnosis, I think these baseline nutritional parameters are prudent, and you should start at a dose no less than 40 to 50,000 units of lipase during the meal, and again, use it during the meal. You should determine efficacy based on clinical features and improvement in nutritional measures, and again, if it's not working and there's no other explanation, you can push the dose up to 90,000, I think, and that will usually take care of the problem. Assess for osteoporosis and osteopenia and treat that directly if it's present. And if they're not responding, make sure they're actually getting drug and that they're getting it at the right time. Well, thank you for your attention. These are some pictures from my home institution, including the manatees being very careful, like we all are, and wearing a mask. Thanks.
Thank you, Chris, for a very informative talk. Talk is open for some. I think we have time for 1 or 2 questions. Let me just ask you a generic question. Is PERTs are undersubscribed or oversubscribed in US?
It's a good question, I guess. We don't know exactly what the prevalence of exocrine pancreatic insufficiency. I think I would say in the patients that probably need it, which would be the patients with chronic pancreatitis or pancreatic cancer or previous pancreatic surgery, that it's significantly underprescribed. There's a whole other group of people, as you're aware, sort of the non-specific symptom patients or the diabetics with bloating and that kind of stuff, which is a much larger market. But I think in that group, one could make the case perhaps it's overprescribed.
How about in celiac disease? You mentioned that a little bit in your talk. So is that a real EPI in celiac disease? And or they just need to modify their diet and just be fine?
I mean, there's sort of 2 things in celiac disease that might explain it. One is there might be decreased signaling from the small bowel because it's injured. So, as you know, there's the control of pancreatic secretions runs through CCK largely. And if there's injury to those cells in the small bowel, then signaling may be deficient. And the other is these patients can get sort of strictures of their pancreatic duct due to the small bowel injury, and that may be another reason. But it does seem to be real, but probably only in a subset of patients.
Thank you. I think maybe one more question. Dr. DeMagno, Matt, I thought you have a question. You want to unmute yourself and ask your question? Matt, you're there? I guess we're going to pause, and maybe Chris, maybe you can, let me see if I can. Okay, I'll read his question. It says, Chris, great talk. Do you get pushback from insurance companies regarding requests for DEXA, despite commenting on increased risk of bone fracture with CP-EPI?
I do. It's the frustration we all face, but I think there's adequate literature. You can send it to whoever the physician is that's in charge of denying everything for the insurance company, and through some work can get it approved. But it's sometimes it's like getting enzymes at the right dose approved. It's a process, and a rather painful process.
I think, Chris, you have a couple more questions, or there more might come. Can you please answer them in the chat? I think I see that Suhail has questions and others have. You have a popular talk, so please answer them. Thank you so much. Again, thank you for great talk.
Stay safe, everyone.
Yes. And I'm back to you.
Yes, so next speaker is Dr. Stephen Pendle, and also he does not require much introduction. He is a renowned authority on pancreatic biology and disease, and currently is the director of basic and translational pancreatic research program in Cedars-Sinai, and he leads NIH-sponsored consortium on chronic pancreatitis, diabetes, and pancreatic cancer. The talk is on calcium channel blockade as new therapeutic agent in treatment of pancreatitis.
Good afternoon, everyone. I'm Steve Handel from Cedars-Sinai Medical Center in Los Angeles, and today I'm going to talk to you about calcium channel blockade as new therapeutic agent in the treatment of pancreatitis. The topics I'm going to discuss are, first, general considerations of clinical pathophysiology in pancreatitis, calcium channel regulation in the pancreas, preclinical evidence for the potential efficacy in treating pancreatitis, and early clinical results. I showed this slide first that was published by Jim Norman in 1999, showing the kinetic relationship between the emergency room presentation cytokine production, and organ failure. The point of this slide is that the emergency room presentation precedes the massive increases in cytokines and followed by organ failure that occurs in the most severe cases of pancreatitis, where the pancreatic tissue is necrotic at the later stages of this time course. The point being that Jim and others have suggested that the treatment needs to be initiated early in disease before there is significant necrosis and inflammation. This is a model that we use to describe the inflammatory and cell death responses in pancreatitis that we've used for quite a while. And that is an insult, whether it be hypertriglyceridemia or the obstruction of the pancreatic duct with a gallstone, causes stresses in the acinar cell, and those stresses increase production of chemomodulators that cause attraction of inflammatory cells like neutrophils and macrophages. We found that those in turn can cause further damage of the pancreatic acinar cell, including necrosis and production of organellar dysfunction that causes further activation of trypsin. Here's another slide that demonstrates some of our concepts about how excessive calcium influx, as indicated here, can affect organellar function in the acinar cell. And you'll see that by this slide, we showed that excessive calcium influx can cause mitochondrial failure, autophagic dysfunction, and ER stress. Those in turn can lead to activation of trypsinogen and lead to the formation of pro-inflammatory transcription factors and cell death. The release of the cytokines and chemokines and damage-associated proteins can cause inflammation that can be in the pancreas, but also can lead to the systemic inflammatory response. Although a little presumptive at this point, we suggest that a variety of stresses that can cause pancreatitis from alcohol abuse, smoking, gallstones, hypertriglyceridemia, etc., can include excessive calcium influx that causes these cellular dysfunctions that lead to pancreatitis. The next topic I'm going to discuss is calcium channel regulation in the pancreas, focusing on the acinar cell. First of all, there is a differential concentration of calcium between the extracellular space, here we show at 1 millimolar of free calcium, and the cytoplasm of the cell, which is in the 0.1 micromolar range. So there's a 10,000-fold difference that has to be maintained by the plasma membrane. With increased flux of calcium into the cytoplasm, there's destruction of the mitochondria and other organellar functions. Of importance here is most of the calcium inside the cell is stored in organelles, and here we show the endoplasmic reticulum as a storage. And with stimulation with a hormone, the calcium initially comes out of the endoplasmic reticulum and increases in the cytoplasm. And as I'll show in this slide, with physiologic concentrations of a hormone like cholecystokinin, that release causes transient spikes because the calcium is taken back up into the endoplasmic reticulum to be released again. And each of these spikes is associated with a secretory burst from zymogen granules undergoing exocytosis. However, when we give a much stronger, or we call supraphysiologic concentration of cholecystokinin, what's been observed for several years now is that there's not only this initial release from the intracellular stores, but also there's kind of a sustained increase that actually stays up for a long period of time. That excess calcium then becomes damaging to the organelles of the cell. Here's a very nice diagram that explains a little more detail about the calcium storage and release mechanisms that was put together by David Yule and published in Pancreatic. And this slide focuses on a couple key components. One is ORI1, which is right here. And as you can see, it's part of a regulation of a calcium influx channel. Another is the store-operated channel. And we also call the calcium influx through this complex that's regulated by ORI1, that store-operated channel. The reason we call it the store-operated channel is that it gets activated by a coupling protein called STIM1 when calcium is released from the endoplasmic reticulum that I described into the cytoplasm. That release then activates the influx. Usually there's only a small release caused by an inositol trisphosphate that's made by the receptors that activate the cell. And those, as I said before, are taken back up in the endoplasmic reticulum and prevent the sustained release. However, when there's massive release from the endoplasmic reticulum, you get sustained activation of this channel. The other word that we use here is, or other term we use here is calcium release activated channel. So we use terms kind of interchangeably for the store that activates a calcium that activates this channel that I've been describing. We call it sometimes store operated channel and other times crack operated channel, but they really mean the same thing. The next topic I'm going to talk about is preclinical evidence for potential efficacy of calcium channel blockade in treating pancreatitis. First, I want to acknowledge that the demonstration that agents that could inhibit this crack channel regulated by ORI1 has been described previously in at least 2 of these papers early on by Gerasimenko and Peterson and Wen and Sutton. And we were approached by Calcimedica, who were making the clinical version that's used now in clinical trials that they are undertaking. And we used a compound that they've used for clinical trials called CM4620. And what we show here is that in different kinds of cells, cells from pancreatic acinar cells from different species, from mouse to rat to human, actually are affected by this compound in a beneficial way. And here we measure propydium iodide uptake as a measure of membrane permeabilization and necrosis. And we stimulate cells with either taurolithocholic sulfate or high doses of CCK. And you can see that compared to control, each of those stimulants cause an increase in propydium iodide uptake, but that's blocked both in mouse and in rat as well as human acini by the CM compound that's, again, a ORI1 channel inhibitor. This slide shows that CM4620 blocks carbachol and TLCS induced trypsin activation in human acini. And so these are different concentrations of carbachol as well as TLCS, showing that trypsin activation is prevented with CM4620. And another important experiment for us was to show the effect of CM4620 on the oxidative burst in human neutrophils. And what we did here is we stimulated neutrophils with F-metlu-Phe, which is a agonist for neutrophils that causes a reactive oxygen species burst. And here we see what happens in untreated neutrophils and then treated with CM4620. And you could see there's a significant decrease in the oxidative burst, suggesting there's effect on the inflammatory cells as well. And previously we had shown that neutrophils are a mediator of trypsin activation inside mouse tissue, mouse pancreas tissue. Then I'm going to show you the effect on whole animal experiments. And here we use rats, and we treated them, or to cause pancreatitis, we treated them with cerulean at the high doses that causes pancreatitis. And these are the times of stimulation with cerulean or saline. And then we started on the CM compound at different concentrations, as you see here, as IV infusions, starting at 30 minutes after the initiation of pancreatitis. This picture just shows typical pictures that we see of pancreatitis with widening of the spaces between the lobules, which represents edema, inflammatory cells that I'm pointing out here, as well as the large vacuoles that represent dysfunctional autophagy and the blowing up of the autophagic vacuole. When we treat it with 4620, you can see there's a marked improvement in all the features that I've shown in the previous slide. We measured many biochemical markers and histologic markers in this tissue, but I'll show you just a few. And here we measured trypsin activation with the compound in non-cerulean treated animals, then cerulean treated animals at different concentrations of CM compound. And what you could see is that you caused a marked decrease in trypsin activation. We also followed measures of cell death in this slide and showed that in these markers that we had decreases in a cell death activating pathway, CHOP, for example, by the CM compound. The next thing is that we measured inflammation, and I'll show you here in the pancreas, and in the next slide I'll show you in the lung. And we measured myeloperoxidase activity, and we measured myeloperoxidase RNA, but we also measured RNA for TNF-alpha and IL-6. And what you can see that basically is for each of these inflammatory signals, we saw that the CM compound would, at all the doses we used, markedly decrease these inflammatory signals. And the same thing was true for lung inflammatory responses measured by the same signals. And you can see with our cerulean treatment, there was a significant increase, marked increase, and these were dramatically decreased with the CM compound. So that is about the ORI1 inhibitor, CM4620. And I wanted to show you just data that was reported just recently by Swain and Little and JCI. And they've identified another calcium entry pathway that probably is going to be pretty important as well. And what they demonstrated is that there's a calcium activating, the activated channel called piezo-1 that's activated with pressure. This could account maybe for how gallstones transiently stuck in the ampulla bladder could cause pancreatitis by increasing pressure, and that could cause the calcium increase. They also showed that piezo-1 effect could affect TRPV4, which is another calcium channel through a pathway involving phospholipase A2 activation. But again, they showed that this increase in calcium could cause organellar dysfunction, including mitochondrial depolarization, decrease in ATP, as well as trypsin activation. So this means there's another calcium entry pathway we have to consider. So the final topic is any evidence of benefit in early clinical trials. So using the same compound that I've described, there are, Calcimedica has completed phase 1 safety trials that were without safety concerns, and they have been given the green light by FDA to go forward to phase 2 trials. They, however, have been sidetracked by the COVID pandemic and actually had the opportunity to use this agent, and it's called, in a trial that was published recently, Oxora. And they used Oxora versus standard of care for the treatment of severe or critical COVID-19 pneumonia in a randomized controlled trial. And it's reported in this paper that just came out. And they demonstrated with a small number of patients, there's a potential benefit. It's a small number, but the signal is positive, suggesting that there'd be a benefit. And this actually reflects back to what I showed you earlier, that this agent can have effects on inflammatory cells like neutrophils specifically. So this agent may be used in other acute inflammatory situations. So in conclusion, pharmacological inhibition of ORI1 blocks CRAC, or store-operated channel, CRAC, calcium release activated mediated pathologic calcium entry into pancreatic acinar cells. Inhibition of ORI1 has a potential benefit in acute pancreatitis by having independent effects both on pancreatic cells and inflammatory cells. Phase 1 clinical trials have been complete, and phase 2 trials are pending for acute pancreatitis treatment. ORI1 inhibitors are promising drugs to treat acute pancreatitis in humans. And as I indicated in the end of my talk, there's another player in the calcium entry pathway to consider, the piezo-1 channel. I want to acknowledge my collaborators and the people who did the work. At Cedars, Richard Waldron, Aurelia Lujea, Chang Hu, and Yafeng Cheng. We had help from Sohail Hussein at Stanford University, and our collaborators at Calcimedica, Michael Dunn and Ken Stotterman. Thank you so very much.
Thank you, Steve. Very interesting, very clear, informative talk. Are you in?
Yes, do you hear me?
Yes, very good talk. So I wonder if this your inhibitor or other calcium entrance inhibitor affect physiologic function of acinar cells, like basal and CCK-induced secretion?
That's a very good question. We did demonstrate, we worked mostly on blocking refilling of the stores with calcium, and it does prevent refilling from extracellular calcium. We worked less on the physiologic function, and I think that's something
Okay, thank you very much. And another one, I do not, okay, before I look at the chart, my understanding from the last papers by Gerasimenko and Peterson that CCK release calcium mostly from acidic pools. So how does it affect the ER calcium and leading to increase in calcium entrance?
Oh, so you're asking what the connection between non-ER stores is and ORI1 regulated channels.
Yes. So how this release of calcium from acidic pools by CCK would lead to depletion of ER calcium and activation of cracked channels?
Well, that's a great question. I don't think we know that yet. There must be some kind of mechanism to maintain store levels, but I don't know what the regulation of those stores are with the extracellular influx, but they must be connected. I just don't know the exact mechanisms.
Yes, and you have several questions on the chart. One from Shmuel. Hi, Steve. Great and clear talk. What is the effect of CM on the physiologic calcium and amylase release responses, and how well it is tolerated both in mice and humans? So it partially overlap with my question.
Yeah, so I answered it there, and the phase 1 trial shows a good tolerance by human subjects. So I do think we'll call it the basic science understanding of the pools and role in physiology is important. I believe we should still move forward with the clinical trials.
And Murray Corcas, great talk, Steve. What about ryanodine receptor inhibitors, and where were the neutrophils in the rat that got cerulean too early?
So the ryanodine receptor, yes, blocking ryanodine receptor calcium release would be important. And so Hill showed that several years ago, that would have a benefit. So that's another potential intervention. And I think what Murray's second question was, did we give the therapy too early? So that's an interesting question. We did give it at 30 minutes. I showed early in my presentation that Norman and others have suggested we start treatment early to have the maximum benefit. But what I'm starting to think is that later complications like pulmonary inflammation and other extrapancreatic organ injury that's mediated by inflammation could benefit by treatment with an agent like this. So I have my mind open a little bit. Those are going to take clinical trials to figure out.
And Aurelia Lugia says that CCK also releases calcium from ER. And you have a couple more questions to answer on the chart. And many people really thank organizers, because this is the last session, thank organizers for this meeting. And indeed, it was great, even though we had, all these conditions. So we should Thank a lot. Ashok Saluja, Rastgi, and the whole team for doing this. This was really great.
Thank you, Anna. And,
I was going to
Thank you.
comment too. What is so amazing
Please.
to me is how you work the pre-recorded lectures together with the in-person lecture. It was amazing. It was smooth.
Yeah.
It did go very well, and I see that Joanna is here from Finland. Welcome, Joanna. Great, thank you. So I think, Anna, let's close this session. Thank you, everyone, all the three amazing speakers and great talks, and everyone else for staying. I know it's towards the end of the day on Sunday. So thank you so much. We will continue now to our